for inviting me. I'm going to speak today on retention and re-engagement. I want to start off by saying that the science, I believe, is clear for HIV treatment and prevention, but as raised by my colleague Judy Auerbach yesterday, the science behind what to do about retaining people in care and re-engaging is very much of a baby science and very much in need of more research, and it's exciting to hear a lot of studies that are underway. Let me just say today in my 10 minutes, I'm just going to talk about the significance of the issue, the early successes, what do we know, what has been published to date on interventions, particularly for retention and re-engagement to care, and interventions to come. I just have a couple of colleagues. I want to highlight a person who's not here, Michael Mugavero, who was very generous to share some slides that I'm going to present in part today, and then some other colleagues who you can all see in the room. And then one colleague, Marilena Lakis, who is working with me as well at Columbia. So in terms of implications, Carlos just presented of poor retention and care, I think is obvious. If you don't go to care and you don't see the doctor on a regular basis, you're not going to get on antiretroviral therapy. You're certainly not going to be successful at adhering to care if you're not in care. In terms of inferior CD4 viral load, emergence of HIV resistance, there's also been, clearly shown with HPTN 52 and other studies, the population level of effects of not being on ART and, of course, not staying in care. But let's get back to the science. So what do we know about factors associated with poor retention and care? The studies to date have shown individual level factors, have shown comorbidities, mental illness, substance use, passive referral to HIV medical care. So very early on, when you first find out your diagnosis, if you don't have that early linkage to care, you're going to be much less likely to be continued to be retained in care. But if I put my social scientist hat on, I can really feel that a lot of the studies that have been done to date and the work has not really looked at the holistic point of view that has been pointed out at this conference. So if we want to talk about making sure that a person is going to come to HIV care, we have to realize that an individual living with HIV has had a whole lifetime of opportunities and constraints as they interacted with the healthcare system, as they've grown up in families and cultures that may weigh health and health seeking in different ways. There's a sociological term called habitus that comes out of Bourdieu's work that really looks at the interplay between individual decisions and the social structure. And I know there are many physicians in the room, and a lot of times you think of habitus and you look at the person's weight, or you make certain decisions on the kind of treatment they're going to have. In looking at someone's healthy lifestyle, if we're treating a person who is spending most of their time and energy trying to acquire drugs, and they may not end up wanting to go to care until they get very sick. And I think it's really important that we look at all the cofactors, and for some people who are more worried about feeding their families or housing, the thought of again, coming to care on a regular basis may not just happen. So I wanted to put forth, this is work that comes out of an NIMH study that I'm doing with Marilena Lakis at Columbia, and we're doing qualitative interviews bedside to try to understand person's healthy lifestyle and how they make decisions with the hope of informing new interventions. So what are some of the early successes? As Jose pointed out, last year in the Annals of Internal Medicine, the recommendations for early intro and retention and care were put out, and there were 5 strategies that were shown to work to date. One, of course, was the systematic monitoring of entry and retention and care, so using surveillance databases, using administrative data systems. I mean, Amanda Castellan spoke about some of that this morning, and other people monitoring, and that is certainly a very highly successful strategy to try to monitor retention and re-engagement, and these are some of the studies that have been published in different cities in the U.S. In terms of in terms of randomized trials, so I had the pleasure with Carlos, and I know Stephanie Strafty somewhere in the room, participating in the ARTIS study, which was CDC funded. It was funded over a decade ago. It was the first randomized trial to look at linkage to care. And unfortunately, in the literature, at least to my knowledge, it still remains one of the few, if not only randomized trials that have shown to be successful in linking newly diagnosed people to care. That early study used strengths-based case management, which again was one of it, when we have here, was rated 2B, which going here was, is high with moderate effect in terms of linking people to care. That early study had initial good linkage. As we followed people over time, we saw that, the effect of the intervention did decrease. Another study that also was recently published in Clinical Infectious Disease was a clinic-wide intervention, which also was headed up by Lit Gardner and other colleagues at the CDC. And in this intervention, this was the first phase of a two-phase study. The randomized trial results are coming soon. But this first part of the study, where what we did is we worked in 6 clinics in the United States in inner cities, and we got the providers to talk about retention and care. We hung up posters, and we monitored the effect of this by comparing some of the clinics that did this and some of the clinics that did not. And we also showed that this had an effect on getting people to be virologically suppressed, as well as increasing attendance in clinics. This was some of the literature that was hung up in the clinic: stay connected to health, come to all your appointments. And the whole idea was to try to saturate these clinics by giving these messages of coming to care. Then moving to substance use, a matter very close to my heart and where a lot of my recent studies are. Nora and Julio published in Health Affairs and in JAMA the urgency of integrating substance use treatment into HIV care. There's an exciting new study being planned in the NIDA Clinical Trials Network that's going to look at that, and this was a study published by Gregory Lucas that came out of a HRSA Beehives initiative that integrated opioid drug treatment into HIV care, and again showed in this single site study successful outcomes in terms of reducing and increasing attendance and care. NIDA-funded project Retain, which I'm doing with Carlos, is a randomized trial that's funded to integrate this. We're working here with cocaine users, and what we're trying to do is to test an HIV retention clinic to improve clinical outcomes. And this was based on earlier work that Carlos and his team did at Grady, which in this retention clinic again in the Deep South, where we have people who are rotating in and out of care, we integrate primary care, mental health, substance use, harm reduction, and some of their early data, which was preliminary data for our grant application, showed that that people who participated in this retention clinic before 6 months before they had participated, they were 9% had virologic suppression, and then 6 months later, 42% were able to have to be suppressed. So again, the idea of integrating again substance use, mental health into HIV care. What about re-engagement? So on the Cascade, there isn't a box normally for re-engagement, noticing that people who may be retained in care one day will be out of care the next. And we heard a lot about, and we'll continue to hear when Anne speaks about the criminal justice system in a place certainly where you can find people who've dropped out of care. Another setting, particularly where you can find substance users, is in the hospital. Many of you who are clinicians know you may see an outpatient population that comes to care on a regular basis, and then you'll see people in the inpatients in the hospital wards. And we would think in the era of HAART that we wouldn't see patients anymore in the hospital, but unfortunately we do. And it's a really great place to try to intervene with people and get them back linked to outpatient care and hopefully onto antiretroviral therapy. And we're doing a study in the NIDA Clinical Trials Network called CTN 049 Project Hope, where we're doing a 3-arm randomized trial engaging people living with HIV at bedside who have detectable viral loads, and in this study have CD4 counts under 500, and we are engaging them into a study where they're randomized to either patient navigation services, patient navigation plus financial incentives, contingency management, or treatment as usual, and we're going to follow them for a year to hopefully get them virologically suppressed and then to follow all the steps that come along with it. And finally, I just want to mention a last study that involved with, it's also focusing on retention and engagement in care. My colleague, Dr. Jorge Santana, is here from University of Puerto Rico in San Juan, Puerto Rico, and Julio and others were very involved in helping us get this study rolling. And we're going to be testing the whole seek, test, treat, and retain model to evaluate a community-level comprehensive structured intervention. Essentially, this study working in San Juan, which has elevated rates of HIV, particularly among injection drug users, is going to involve an HIV testing campaign, a treatment re-engagement campaign, a patient navigator linkage to link people to HIV care and substance abuse treatment, and then a mobile HIV care clinic. And we're going to have an assessment cohort that's going to start at the beginning to monitor the impact on that cohort as we saturate different neighborhoods in the San Juan area. And a very important part of that is we're going to be having a mobile clinic that's going to bring HIV care directly to drug users in areas where they're shooting up, and to make sure that they get on antiretroviral therapy and stay on antiretroviral therapy. Thank you very much. And then my last slide before I finish actually is just to summarize. I just wanted to mention about the importance of having a holistic approach to intervention, recognizing the habitus of our patients, proven interventions so far are in the areas of linkage case management, intensive outreach, systematic monitoring, integrating engagement into care in your organizational culture and routine patient care, and then just the criminal justice system and hospitals are also important settings. And the last slide, which you can't see, has been said before, to keep it simple and to bring care to the patients. Thank you.